Hello everyone, my name is Lauren Heinecke and I'm an assistant professor of pharmacotherapy at the University of Maryland School of Pharmacy, and today it's my pleasure to present to you part 4 in our Antibiotics from Head to Toe series. Specifically today we're going to be focusing on endocarditis. So we have 4 objectives for today's presentation. By the end of our time together, you should be able to list the patient populations who are at higher risk to develop the specific disease state of endocarditis. You should then be able to list the most common organisms that are seen in patients who have endocarditis. You will be able to identify signs and symptoms of endocarditis. And finally, based on our knowledge of our common organisms that we see in endocarditis, you will be able to select an empiric antibiotic therapy regimen for a patient with endocarditis. So in terms of the exact epidemiology, it's very difficult to determine the exact incidence of infective endocarditis. And the reason for this is that there's different criteria for making a diagnosis and different methods that are used for reporting incidences in various epidemiologic studies. So it's very difficult to know the exact incidence. Know that infective endocarditis is uncommon, but it's not a rare infection. And so it's, I think, an important one for all pharmacists to at least have a general understanding of. Whether you're in the community or in the hospital pharmacy. So every site really needs to have a general understanding of endocarditis. So I think the other important piece of knowing about endocarditis is it's now considered the 4th leading cause of infectious disease syndromes that are life-threatening. It's after urosepsis, pneumonia, and intra-abdominal sepsis. So I think the important thing to remember is it's not a common disease, but it is a very serious disease. And so a number that I found as I was preparing for today's presentation was 34,000 hospital discharges that listed bacterial endocarditis as the primary or secondary diagnosis. So that's not a huge number, but still one of those numbers that likely means you'll come in contact with someone who's had infective endocarditis. The other piece of, I think, knowing about endocarditis is has to do with the pathophysiology, and when we talk about prevention, I think that will sort of tie everything together in terms of why I think this is an important disease state, particularly for community pharmacists to be aware of. So some of the information about empirically treating might not seem as relevant, but I think the prevention slides will really be relevant, and some of your patients may have questions about prevention of endocarditis. So in terms of our etiology, this is going to help us with one of our objectives in terms of identifying the microorganisms that most commonly cause infective endocarditis. Know that there are many microorganisms that can cause infective endocarditis. However, streptococci and staphylococci species account for 80 to 90% of the cases of bacterial endocarditis. So that's a huge number. So it's primarily a gram-positive disease. So up there on the slide I have listed for you, it's predominantly a bacterial disease. Streptococci account for about 25 to 35%. Staphylococci species account for 45 to 70%. So thinking about things like Staph aureus as well as Staph epidermidis. Enterococci are a slightly lower number, 5 to 18%, and then there is a small percentage that can have gram-negative aerobic bacilli that are causing their endocarditis. And the specific organisms which are laid out in that acronym for you are spelled out on the next slide. We won't spend a lot of time going over those because they are not as common as our gram-positive pathogens. You can have fungal endocarditis. About 1 to 4% of patients will have fungal endocarditis. Mixed infections can be seen and are probably the most common in intravenous drug users. Only about 1 to 2% though are mixed infections. Then you can have culture-negative endocarditis. It's been reported anywhere to as less than 5 to 24% of cases of infective endocarditis are culture-negative, meaning that they do cultures but never actually get a pathogen. So one of the things that I think is very interesting is that the trend of staphylococci being more common than streptococci is actually more recent. So previously the most common cause of infective endocarditis was really streptococci viridans, which is actually an oral flora. And we'll talk a bit about why that probably was when we go over the pathophysiology of the disease. Now, unfortunately, staphylococci, particularly Staph aureus, really are increasing the number of cases of infective endocarditis, and a lot of that probably is a result of transient bacteremia that has resulted because of healthcare contact. We'll talk about that transient bacteremia when we get to the pathogenesis. So just quickly to go over valve involvement, because we do know we have multiple cardiac valves. So the ones that are most commonly infected are the mitral and our aortic valves. So we've talked a little bit about transient bacteremia and how that results from streptococci as well as staphylococci. But you can also have transient bacteremia occur with enterococcal infections as well. Particularly, enterococcal endocarditis tends to follow any sort of genitoureteral manipulations in an older man or in an obstetric procedure in a younger woman. So just a couple of things to keep in mind when you're thinking about risk factors and which microorganism is going to be most likely. Now, we'll talk a lot about this as we go throughout the presentation, but I just wanted to throw a little bit of that information now while we're talking about etiology. So as promised, those gram-negative pathogens, so gram-negative aerobic bacilli that can cause endocarditis in 1.5 to 13% of patients are listed up here for you, not organisms that we commonly talk about. As I've mentioned, we're really not going to spend any more time other than this on these microorganisms because they are not the most common, and I don't think they're the best use of our time, but I wanted you to be aware of these microorganisms. That brings us to talking about the pathogenesis. So we've talked a little bit about some of this as we've gone through the etiology. But the development of infective endocarditis predominantly occurs via hematogenous spread, meaning it spreads through the blood. And so you have this sequence of multiple different items that occur that ultimately lead to the infective endocarditis. So the first thing that has to happen is that the endothelial surface of the heart is damaged. And what happens is that this injury occurs and there's turbulent blood flow that's associated with maybe some valvular lesions that have developed previously. Ultimately, some of the things that can cause this damage can be congenital. There can be cardiac dysfunctions, lots of different things that can lead to this first part of the pathogenesis. The next piece of this is that you have platelet and fibrin that deposits on the abnormal epithelial surface. And ultimately, you may have heard of this before, but these platelets and fibrin deposits are then referred to as non-bacterial thrombotic endocarditis. So it's not infectious at this point, but you essentially have the perfect setup now to develop a vegetation. So after you have this platelet and fibrin grouping or clumping that has formed on that epithelial surface, essentially what you have is some sort of procedure or everyday event, such as brushing your teeth or a dental procedure, that leads to a transient bacteremia. Ultimately, that transient bacteremia leads to colonization of that platelet and fibrin area that has developed on the epithelial surface. And so ultimately, that is what leads to essentially the colonization or the development of the infective endocarditis, the infected vegetation. So I think the next important piece of this is that the vegetation is on the valves. You've got bacteria, platelets, and fibrin as part of that, and that ultimately is what is making up that vegetation located on the valve. This is not always the case, but the vegetations actually can break off, and ultimately this leads to a phenomenon called septic emboli, and these septic emboli can really travel anywhere. They can travel to the lungs, the brain, the kidney, the spleen. Those are just some examples, but really these septic emboli can travel anywhere and cause vascular manifestations as a result. So we'll talk a bit more about that when we get to talking about the clinical presentation in just a couple of slides. But, I think the really important thing to remember is that the damage first has to occur, and then you have to have a transient bacteremia that then leads to the seeding of those platelets and fibrin that have deposited on the endothelial surface. Okay, so now that we've got the pathogenesis under our belt, how do these patients present? Well, they're going to present very similarly to how many other infectious disease patients present. So a lot of things that are non-specific and really fairly constitutional. So about 80 to 90% of patients will present with a fever. 40% will have chills, dyspnea, and weakness. A quarter of our patients may present with sweating, anorexia, as well as malaise and weight loss. 20% will have skin lesions, nausea, vomiting, and headache, and we'll talk specifically about those skin lesions when we talk about our objective data, and I'll show you some pictures. They may complain of arthralgias and myalgias. Delirium and back pain are much lower in terms of how people present. So again, none of these signs or symptoms is really going to necessarily lead you down the path of infective endocarditis, alone. You may also be thinking about other disease states. So what other objective findings do we have that make us think about infective endocarditis? So again, I have fever listed up there, again, 80 to 90%. About 85% of the patients will have a new heart murmur. So a new heart murmur, you always want to be thinking, could this be endocarditis? Peripheral findings can be seen in over 50% of the patients, specifically petechiae, and then some things that are not specific to endocarditis, but I think when we talk about them, we typically are talking about endocarditis, and those include osseous nodes, splinter hemorrhages, and Janeway lesions. On the next slide, I have some pictures so that you can get a sense as to what these physical exam or peripheral findings really look like. They can also develop splenomegaly, and the splenomegaly is really a result of both the humoral and cellular immunity really being revved up. So I do just want to take a quick step back and talk just very briefly about the peripheral findings. I think one of the best ways to talk about these peripheral findings is to give you some pictures so that you know really what you're looking for. So the first picture on the left-hand side of the slide is a splinter hemorrhage, and these are not specific to endocarditis. You can see them in other disease states, but I think frequently when we hear about them, we do talk about endocarditis. And the splinter hemorrhages really are occurring in the nail beds and are likely the result of septic emboli. The osseous nodes and the Janeway lesions do look fairly similar. The osseous nodes, however, are raised, whereas the Janeway lesions are flat. We tend to see them in similar locations on the palms of the hands as well as the fingertips. You can also see them on the toes as well, the osseous nodes. And the soles of the feet is the other place that the Janeway lesions can present. So in terms of what causes them, the osseous nodes, we're not 100% sure exactly what causes them, but it's believed to be immune complexes that cause the osseous nodes to develop. And the Janeway lesions are again the result of septic emboli. So some of these peripheral findings I think are very interesting, and again not specific to endocarditis, but frequently when you hear people talking about these findings, they're frequently talking about them in a patient with endocarditis. So hopefully if you've heard these and not known what they've looked like or been confused as to what caused them, you have a bit more understanding relative to that. We also want to take a look at laboratory abnormalities. So we have lots of laboratory abnormalities that occur in patients with infective endocarditis, but again, these are not specific. So we see anemia developing in many of our patients with endocarditis. Leukocytosis, surprisingly, is not going to be found in the majority of our patients. Only about a third will develop a leukocytosis. And some patients also have some platelet abnormalities with thrombocytopenia in a lower percentage of the patients. So the erythrocyte sedimentation rate, or ESR, is really not specific. It's a marker that shows that there's inflammation going on somewhere. This can be elevated in as many as 60% of the patients. And then patients also frequently will have abnormal urinalysis, including proteinuria and hematuria. So we've talked a lot about subjective and objective findings as well as laboratory abnormalities, but really none of these are giving us specifically a diagnosis of endocarditis. So what else would we do to work up a patient with endocarditis? How would we know for sure? I think there are a lot of these things that we've just talked about give us clues that we're considering endocarditis. When we talk about risk factors, that will also lead us down the path in terms of determining maybe who is more likely to have endocarditis. After we go over our laboratory workup on the next slide, we'll go into talking about some specific criteria you can use to determine how likely endocarditis is. So we do have some better tools that we're going to talk about to determine really who's likely to have endocarditis. So in terms of our workup, probably the two most important things are blood cultures. So bacteremia is usually continuous and low grade. And within the first 24 hours, really 3 sets of blood cultures should be obtained. And these tend to be really low in terms of the number of CFUs or colony-forming units. Generally, they have less than 100 colony-forming units per milliliter, so just keep that in mind. As I mentioned, it's usually continuous and low grade. In terms of the echocardiography, this is the other important part of our workup, so it's really how we take a look at the heart valves to see if there's a vegetation. So you can do either a transthoracic echocardiograph, and it has variable sensitivity, only about 60 to 65%, or you can do a transesophageal echocardiograph. So that's a TEE, significantly more sensitive, about 95% sensitive. So a TTE can rule in endocarditis, but it cannot rule out endocarditis. So if you do a TTE and it's negative, frequently, if your suspicion is high enough, you'll go on to perform a TEE. And so I think those are just important things to keep in mind. Obviously, if you're very suspicious, you'd rather get a TEE first. I know in our hospital, because the TTE is less invasive, they tend to want us to do that first. And then if our suspicion is high enough, then we can move on to get a TEE. But if your suspicion is very high, I'm sure if your hospital would do a TEE first, that would be ideal. So that's really all that we have in terms of our laboratory workup. So we've talked about the clinical manifestations that might lead us down the path of thinking about endocarditis, but what risk factors would help put the picture together as well? So patients with prosthetic valves are at increased risk for endocarditis, and about a quarter of the cases that we see are in patients with prosthetic valves. Patients who have a previous history of endocarditis are at risk for another episode of endocarditis. As we've mentioned, if there's an abnormality in the epithelial cells of the heart, this is one of the pieces of the pathophysiology that sets a patient up for developing endocarditis. So congenital heart disease is part of that. Chronic intravenous access really gives a higher risk for the transient bacteremia, and this is going to increase a patient's risk for endocarditis. Diabetes mellitus also increases the risk, as well as rheumatic heart disease, hypertrophic cardiomyopathy, mitral valve prolapse with regurgitation, and intravenous drug use or abuse. So all of these are risk factors that are going to really, I think, give you a higher suspicion that endocarditis is maybe what's causing your infection. So I think the important thing to note, though, is a predisposing risk factor may be absent in up to a quarter of the cases. So you won't always have a risk factor present. Keep an eye out for them, but don't always expect for there to be one. Don't rule endocarditis out because there isn't a risk factor. And that leads us to the Duke's criteria, which is really probably the most helpful criteria in determining if your patient actually has endocarditis. So we have some major criteria and we have some minor criteria, and I'll talk about how you're going to use those criteria on the next slide. Your major criteria is a positive blood culture, and you also included in the major criteria is a positive echocardiogram, so either a TTE or a TEE, as we've talked about in our laboratory workup discussion. Your minor criteria include that the patient has a predisposition, such as intravenous drug abuse. They have a fever over 38 degrees Celsius, so they've got a fever. They have some sort of vascular phenomena, as we've talked about in our slide where we went over specifically the splinter hemorrhages, the Janeway lesions, and the Osler nodes. They have some immunologic phenomena, or they have a positive blood culture that is not considered part of the major criteria. So then how do you go on to use this? So you've got definite infective endocarditis if you have 2 major criteria, or you have 1 major criteria and 3 minor criteria, or if you have all 5 minor criteria. You have possible infective endocarditis if you have 1 major and 1 minor criteria, or you have 3 minor criteria. So I think when I sort of think about how we use the Duke's criteria, the definite is really easy if you have all of your laboratory workup done to really, I think, figure out exactly what's going on. But I think it takes a little while for the blood cultures to come back. It takes a little while for the echo to get done. And so really, I think we start thinking about possible infective endocarditis using our Duke's criteria. And then as we go on to really finish our workup, we can move on to talking about definite infective endocarditis. And as we get more information back, we sort of move throughout this Duke's criteria. So I do think it's a bit fluid in terms of how we should think about it, depending on where we're at in our workup. So we've talked about a lot of information. We've talked about the epidemiology, the pathophysiology. We've talked about laboratory workup and presentation, risk factors and diagnosis. So I think it's time for us to get to the first of our 2 poll questions. And I'm going to use this case for the second poll question as well. So pay particularly close attention. I will represent it. But this is the case of PR, who's a 68-year-old male, presents to the ER with a 1-month history of fever and chills. His past medical history is significant for a mitral valve replacement 5 years ago, and he also has hypertension. He's noted to have a new murmur on physical exam when he's admitted to the hospital. The team is concerned about endocarditis, and a TTE is obtained, which is positive for a vegetation, so we got lucky. We didn't have to move to a TEE. Blood cultures are obtained, and on physical exam, he's noted to have a temperature of 38.5 degrees Celsius. He's also noted to have raised red bumps on his hands. Okay, we have just a little bit more to talk about before we move on to talking about treatment and prevention of endocarditis. These last couple of slides before we move on to treatment are 2 classification slides. I think the most useful way to use these classification slides is to try to figure out what the likely pathogen is that's infecting your patient. Characteristically, endocarditis is classified as either acute or subacute. So acute endocarditis is associated with high fevers and systemic toxicity. So somebody just looks really sick frequently. It happens more quickly. So you're going to have a shorter history of the patient developing their symptoms. And the acute, really toxic looking endocarditis is predominantly caused by Staphylococcus aureus. So think about the time course and really how sick your patient is really looking on presentation. The subacute form is more indolent. It's going to take longer for it to develop, and it tends to be caused by less invasive organisms. Predominantly the one that we see most commonly is Streptococci viridans. So that's the oral flora bug that we talked about. And it's typically seen in patients with pre-existing valvular disease. So you may hear even as long as a month or 2 that a patient has developed the symptoms over with subacute. So just thinking about your clinical presentation can help you determine which bug is most likely. We've also mentioned transient bacteremia a lot, and so thinking about if your patient has specific access, so they've got an IV catheter, or they've recently had a dental procedure, or they've recently had their genitoureteral tract manipulated. So thinking about any sort of procedures or other types of things, just daily, if they've got poor dental hygiene, strep viridans might be more likely. So this patient presentation, as well as thinking about what specific risk factors they have for that transient bacteremia, can help you in determining which bugs are most likely. There also is classification for native valve versus prosthetic valve endocarditis. And there's also differences in how we treat patients who have a native valve endocarditis versus prosthetic valve endocarditis. Patients with native valve endocarditis most commonly are infected with strep viridans, about 60%. And again, remember, this is subacute. About 15% are infected with Enterococcus, 25% with Staphylococcus aureus. Now, in a patient who has IV drug use or abuse, this number changes, and so these patients, about 60 to 80% of them actually are infected with Staphylococcus, usually Staph aureus. So it's important to think about these classification symptoms, the patient presentation, as well as risk factors, and specific types of, really the risk factors lead you to thinking about what type of bacteria really could be involved in terms of transient bacteremia. So using all of these things together really is the best way to determine which pathogens are going to be most likely, and then to help you determine which empiric coverage is going to be best for your patient. So in terms of prosthetic valve endocarditis, We have early and late endocarditis. So if it occurs within 1 year of replacement, staph epidermidis and staph aureus are very common, as well as gram-negative aerobic bacteria and fungi. If it's late, really we start to look much more like native valve endocarditis and include streptococcus species as well as enterococci as well. There are different risks for pathogens depending on your patient presentation, as well as whether it's native valve or prosthetic valve endocarditis. So all important questions and things for you to think of if endocarditis is something that a team is considering. So now we finally get to talk about antibiotics, but I think it's really important to talk about all of this basic foundational information to really help you to understand how we should better use antibiotics in terms of treating endocarditis. So some specific principles when we think about empiric therapies, and I really think I've said this already, but I don't think we can say it enough. So it's dependent on the classification and the patient presentation, and those two things help you determine which pathogens are most likely. Gram-positive organisms, regardless of your risk factors or your classification, are highly likely, and personally I would use vancomycin until I have susceptibility data. So I think vancomycin is a perfect option to cover your staph, your strep, and your enterococci until you have additional susceptibility data. If you have risk factors for gram-negative pathogens, remember we do have about 1.5 to 15% of patients that will develop those gram-negative pathogens. And at this point, I would say consider your antibiogram, particularly if they're at risk for something like Pseudomonas or other highly resistant gram-negative organisms. So I would say consider your antibiogram. And then when determining the regimen, there's a couple of things to think about. You want to select a bactericidal antibiotic. It needs to be high dose and it needs to be administered intravenously. And then you want to settle in for the long haul. Endocarditis is not a quick and easy course. So important things to think about. And these are the key items that I would just recommend as you're thinking about empiric therapy. But I would say the majority of your patients, you're probably going to be fine with starting out with just vancomycin as empiric therapy. We also have some non-pharmacologic treatment that we can use, and really that's just surgery, and so I'm not going to spend a lot of time on this, but it's an important adjunct therapy in the management of native valve endocarditis. So there are some specific echo features that suggest the need for surgery. Those are specifically a persistent vegetation or an increase in the vegetation size after antibiotics. This would mean that your antibiotics really aren't working. They're not able to get to the infection. They're not effectively treating it. If somebody has valve dysfunction or a paravalvular extension, which essentially is the development of an abscess, or sometimes there's a role for surgery if someone has resistant organisms. So those are the things that are going to make you think about getting a surgeon involved. So now that we've gone over our non-pharmacologic option, really just surgery as an important adjunct, we'll move into the rest of our presentation where we're really going to focus on antibiotic use in endocarditis. So just to sort of start, beta-lactam antibiotics are the drugs of choice for strep, staph, and enterococcal infections. And remember, these gram-positive bugs are going to cause the bulk of your infection. So we're really going to focus on the treatment of strep, staph, and enterococcus in both native and prosthetic valve endocarditis for the rest of the talk. So because that's going to be the bulk of what you would actually see in clinical practice. So I know that this table is busy, but I thought that the easiest way to present this is treatment for native valves and treatment for prosthetic valves by organism. And really what you see in the table is that there's 2 rows for Streptococcus viridans, 2 rows for Staphylococci, and 2 rows for Enterococcus. And the reason for the 2 rows is the first of the 2 for each organism is giving you the treatment options for penicillin susceptible organisms or oxacillin susceptible. And then the second row is giving you the option for your resistant organism. So I thought that this was sort of a nice way to organize it with your organism, your treatment options, your dosage, and your duration in weeks for native valve, and then you'll see a similar chart for your prosthetic valves. I thought that this just sort of simplified everything. Now at the very bottom left-hand corner you'll see the citation for the guidelines. You can all access these if you go to idsociety.org. and you go to their guidelines page. The way the guidelines organize your treatment options are by organism. And so there's a penicillin susceptible strep viridans and a penicillin resistant strep viridans for native valves, and then the same charts for penicillin resistant. For prosthetic valves. And I thought that having the next 20 slides dedicated to all these different tables would just make it too confusing. So I've tried to simplify it, but if you need to see each of those different charts because me talking through things is confusing, please go to the guidelines and take a look. So now that I've sort of given you a lay of the land, let's just talk through what's in the in these tables. So penicillin susceptible strep viridans, you have a couple of different options. You can use penicillin G or ceftriaxone with the dosing that I have listed up there for you. Now, note that with your penicillin G, you can do it continuously or every 4 to 6 hours in equivalent doses. So it does make ceftriaxone seem like a more nice option, especially from a nursing perspective or from a line perspective if you're in an ICU setting. Now, you do note an asterisk by both of those options. There is the option to add gentamicin to either regimen. And if you add gentamicin, there have actually been studies to show that you can shorten your duration to 2 weeks for both therapies. So now, instead of having a 4-week duration, you have a 2-week duration. Now, the guidelines then highlight the fact that adding gentamicin is only for specific patients. It should be only patients who do not have cardiac or extracardiac abscess, or those who have a creatinine clearance less than 20 mils per minute. And then, the other thing that I would just highlight there is that if you have someone who's going to be more susceptible to renal dysfunction, this would be a person that I would consider not using the 2-week gentamicin regimen for. So your elderly patient, maybe your diabetic patient, I would really consider only using it in your very healthy patient who's not going to be at increased risk for nephrotoxicity. So know that that is an option, but I would just keep it in your back pocket in terms of whether or not you want to use it in terms of the patient's risk for nephrotoxicity. So then if you have penicillin-resistant strep viridans, you can use your same regimen, the penicillin G or ceftriaxone, in combination with gentamicin, or you can use vancomycin. And the vancomycin dosing is going to be 15 milligrams per kilo every 12 hours. The duration for that is going to be the 4 weeks. And if you go with a penicillin ceftriaxone with gentamicin option, you're going to be for 4 weeks now and not for the 2 weeks. But the gentamicin is only going to be for the first half. So gentamicin is 2 weeks regardless, but now you're doing your penicillin and your ceftriaxone for an additional 2 weeks. You're still doing a 4-week regimen for those patients. When we talk about vancomycin, I didn't include a specific monitoring section, but you're of course going to want to do troughs, and you're going to want higher troughs to ensure that you have adequate penetration into the vegetation. So I would typically shoot for a trough that's closer to 20 to ensure that I have adequate concentrations where I really need them to be. So those are your treatment options for strep viridans. Now your options for staphylococci now are going to be nafcillin or oxacillin or cefazolin, and I have the dosing listed up there for you. I'm going to use that 12 grams every 24 hours, but it should be in 4 to 6 divided doses, and the cefazolin is every 8 hours, so we're talking about something that might be a little bit easier to administer from a nursing standpoint as well as from tying up an IV line standpoint. You see that little asterisk again, and what that means is you have the option to add in gentamicin. And I didn't specifically talk about why the addition of gentamicin, but gentamicin actually provides synergistic killing of the bacteria. And so that's the reason why with the penicillin susceptible strep viridans you can shorten your duration, and with the penicillin resistant strep you can continue to use the penicillin or the ceftriaxone in combination with the gentamicin. So it's a synergistic effect in terms of being able to kill the bacteria. You would never use an aminoglycoside just by itself though. Okay, so if you have oxacillin susceptible staph, you can use it in combination with gentamicin, but you do not have to. In terms of the length of time that you would use the gentamicin, with staph it's actually only 3 to 5 days. And I think at this point I would just mention that specifically with staph endocarditis, native valve endocarditis, the addition of the gentamicin did not improve outcomes, but it increased the rate at which negative blood cultures were obtained. So it helps you clear your blood cultures faster. So in someone with a native valve staph endocarditis, I would probably not add gentamicin because it's really not buying you anything. Your duration of therapy is still going to be 6 weeks whether you add gentamicin or not. So I would advocate for not adding gentamicin in these oxacillin susceptible staph native valve infections. Now, if you have oxacillin-resistant staph, again, you can use nafcillin, oxacillin, or cefazolin in combination with gentamicin. And again, it's that 3 to 5 days. So regardless of your susceptibility, you have the option to add gentamicin to be able to use your beta-lactam antibiotic, but it does not decrease your duration, and it's 3 to 5 days. Really, I would say that in these patients, the value of the gentamicin really hasn't been proven. These are not groups where I would necessarily use the gentamicin. And so then oxacillin-resistant staph, you have your option to do vancomycin. Again, same dosing as strep viridans and same goals for your troughs. We're treating for a total of 6 weeks in length. Then our last 2 rows are Enterococcus. And there are even more tables for Enterococcus, but I tried to keep it a little bit more simple, just talking about penicillin vancomycin susceptible versus penicillin vancomycin resistant. So when it's penicillin and vancomycin susceptible endocarditis, you have the option to do ampicillin or penicillin G or vancomycin. And you're going to want to use any of these regimens with gentamicin. Enterococcus is not nearly as susceptible to these antibiotics as your strep or your staph, so you really want that synergistic effect with the aminoglycoside, and you're going to use the aminoglycoside for the same length of time as your other antibiotics. So we're talking about 6 weeks for all the antibiotics that you would be using. And then the dosing is the same as the dosing for the antibiotics and the previous infections as I've described above. Now, if you have E. faecium or E. faecalis, it gets a little bit more complicated. These are more resistant organisms. You're going to do 8 weeks of therapy for all of your regimens, and on the very next slide, I'm going to talk specifically about these regimens. So for E. faecium, your options include both linezolid and quinupristin, dalfapristin in the dosing listed above there. E. faecalis is intrinsically resistant to quinupristin, dalfapristin, so you can use imipenem, celastin plus ampicillin or ceftriaxone plus ampicillin. These are the 2 regimens that are recommended in the guidelines. This is not included in the guidelines, but I would say that another potential option is the use of daptomycin for resistant enterococcal endocarditis infections. I would go at the higher end of the dosing, probably around 8 milligrams per kilo, but I would say that that is another option, although it is not included specifically in the guidelines. There have been some case reports and publications saying that it would be an adequate option, but it does get a bit more tricky to pick an appropriate option for resistant enterococcal infection. This next slide I included because I think the gentamicin dosing also gets a bit confusing, and I think the duration also can be a little bit confusing. So I thought it would be important for us just to take a couple of minutes to talk a little bit more about gentamicin dosing by pathogen, and for me just to be able to reiterate the duration depending on the pathogen and how you're using the gentamicin. Because I think the gentamicin dosing and duration can be relatively confusing based on the type of pathogen and the type of valve that's involved as well as susceptibility, I wanted to just include this slide so we can talk about gentamicin dosing by pathogen as well as valve type. So we haven't talked specifically about prosthetic valve treatment. It's going to look relatively similar to our native valve treatment, just a couple of differences and some bit longer treatment durations, but I wanted to just take this minute to clarify gentamicin dosing on this slide. We'll spend a little bit less time than when we get to the next slide talking about prosthetic valves. So the way I have this organized is by organism, and then the gentamicin dosing and frequency is then in the next column. So I'm going to talk you through this. So you have Streptococcus viridans. The recommendation is to do 3 milligrams per kilo daily. Certainly that could change depending on a patient's renal function, but we're just talking about in general. The duration, if you have somebody who has native valve endocarditis, regardless of the susceptibility of that strep viridans, you're going to be doing 2 weeks. Remember, if you have susceptible strep viridans, you're going to be doing your gent plus your beta-lactam or your vancomycin for 2 weeks, and you can decrease your total duration from 4 to 2 weeks. If you've got a resistant pathogen, you're going to be doing that gentamicin for the first 2 weeks of therapy, then finishing up with your beta-lactam for the last 2 weeks. And that's a native valve endocarditis. If you've got a prosthetic valve and you've got susceptible strep viridans, you're going to be doing only 2 weeks of your gentamicin. Then you're going to finish up the rest of your duration with beta-lactam or vancomycin. And then if you've got a prosthetic valve and it's a resistant pathogen, you're going to be doing a total of 6 weeks of gentamicin in combination therapy. So that's strep viridans. In terms of staphylococci, so there's multiple different types of staph epidermidis, staph aureus. So if you've got native valve endocarditis, regardless of susceptibility, you're going to be doing 3 to 5 days. Remember that the only benefit is that you clear your cultures faster. It doesn't impact morbidity and mortality. So this would be an area where I don't necessarily know that I would include gentamicin for everyone. Now, if you've got somebody who has a prosthetic valve, you're going to include your gentamicin for a total of 2 weeks, regardless of susceptibility, in addition to your other agent. And again, for both staph and strep, you can do once a day dosing. Again, taking a look at your renal function and adjusting as appropriate. Now, Enterococcus is a little bit different in that regardless of Enterococcus susceptibility, regardless of the type of valve, you're going to be doing 6 weeks in general of gentamicin. There are some cases where you might be able to shorten it to 4. And then your dosing needs to be divided in 2 or 3 equally divided doses. And a lot of this has to do with the pathogen as well as your antibiotics itself. So gentamicin has difficult time penetrating into the Enterococcus, but the Enterococcus is relatively resistant to our beta-lactam antibiotics. So the reason that you need to have it in divided doses is because the beta-lactam, which acts on the cell wall of the bacteria, allows then your aminoglycoside to penetrate into the bacteria and induce that bactericidal effect. And remember that your beta-lactams, generally Enterococcus is relatively resistant to them. So it really is a synergistic effect, and you're utilizing that to maximize the ability of both of your antibiotics to work to combat the infection. So Enterococcus is a little bit different. It's important to use it in those divided doses, and in general you're going to be using 6 weeks of both the aminoglycoside plus the beta-lactam or vancomycin or potentially alternative drugs, depending on your resistance pattern. So hopefully that sort of summarizes how to use your gentamicin, and hopefully everybody feels relatively comfortable with how you're going to do that. But certainly if anyone has any additional questions at the end, I would be happy to answer them. So to finish rounding out our treatment discussion, this slide talks about prosthetic valve treatment. It looks the same as our native valve treatment slide, and actually there's many similarities. The one thing that I will point out is the duration for all of our organisms now is going to be 6 weeks, unless we have some very resistant Enterococcus, and we're looking at longer treatment durations, again greater than or equal to 8 weeks. But now we're really looking at a total of 6 weeks duration. Now in terms of the strep viridans, we have the same treatment options as what we talked about for native valve endocarditis. So if you have very susceptible strep viridans, you can do the penicillin G, ceftriaxone, with or without the aminoglycoside. The aminoglycoside, gentamicin, again, is going to be for 2 weeks. In terms of your resistant strep viridans, same options as our native valve endocarditis. Now a bit of a different option comes into play when we're talking about our Staphylococcus aureus. So really, depending on our susceptibility, our options are the same. The difference really comes in terms of the addition of rifampin. And so regardless of our susceptibility, regardless of the regimen that we're going to be using, we're always going to add rifampin. And the rifampin should be added for 6 weeks, so really the same duration as the vancomycin or the nafcillin or the oxacillin. The gentamicin, again, if we're adding it, is going to be for 2 weeks. And so the big important thing about rifampin is, and the tricky thing with staph is very sticky and can actually form a biofilm on the prosthetic valve. And so rifampin actually helps to penetrate that biofilm to allow the other antibiotics to get into that valve and to be able to eradicate that organism. So the difference with our staph in our prosthetic valve is now we're adding rifampin. The nice thing about our enterococcal infections is they are exactly the same, the treatment options for native and prosthetic valve endocarditis. And in the guidelines, the treatment recommendations are actually listed together. So that is our whirlwind trip through antibiotic use in endocarditis. I'd say this was probably the most complicated disease state that we've talked about thus far in the series. So our second of our 2 poll questions is back to our patient PR, who was our 68-year-old male. He presented to the ER with a 1-month history of fever and chills. Remember, his past medical history is significant for mitral valve replacement 5 years ago, as well as hypertension. He had that new murmur on admission. Remember, he had that TEE that had a vegetation. They got blood cultures. He had a fever on physical exam. And remember, he's the one who had those red bumps or the Osler nodes on his hands from our previous poll question. So just a couple more things to do before we finish up the presentation. So a couple of things I think in terms of treatment principles that we haven't talked about yet. In terms of how you count the days of antibiotics, day 1 of antibiotics is the first day of negative blood culture. So you're going to start, the first day that you have presumptive endocarditis, but you're not going to count your first day of antibiotics in terms of your 2 or 4 or 6 weeks or whatever you determine the appropriate duration is. It's going to be that first day of negative blood cultures. You need to get then 2 sets of blood cultures every 24 to 48 hours until you obtain negative cultures, and this is really going to help you in terms of ensuring you have a treatment regimen that is going to be effective, and it also is important in determining your duration. I think the next interesting thing is that if somebody is going to undergo valve resection and replacement, if that's deemed to be necessary in someone who has native valve endocarditis, they do need to receive perioperative antibiotics that are for a prosthetic valve. So you would initially treat based on our native valve discussion, but after that you're going to use the prosthetic valve regimens. And so in terms of how you determine the duration, if the resected tissue is still positive for the organism on culture, the patient really needs to undergo a full duration of antibiotics for prosthetic valve endocarditis with that organism. If the resected tissue is negative on culture, then the patient's duration should be the length of time left from the initial antibiotic course. So a lot is going to be dependent on if they've cleared their cultures and that tissue is now negative in terms of how you determine the duration. And the last piece of this is that, remember, if you're using combination therapy that really is done for synergy, it needs to be done at the same time or close together to maximize the synergistic killing effect of those antibiotics. So just 4 very important principles to keep in mind as you're going through and taking care of these patients. The very last thing that we're going to talk about is prevention. So, and there's 4 things we're going to go over: why, who, when, and with what. So why do we do it? Well, we do it really because of transient bacteremia that can result after some dental procedures. Now, there's lots of things that can cause transient bacteremia, but dental procedures is currently when we're talking about really providing this prevention against endocarditis. The WHO has really changed in the guidelines, so there's been a pretty recent update in the last, I think it's about 3 years, in terms of who should be receiving prevention. So it's really those patients who are at high risk for developing endocarditis. They have a risk factor that we talked about earlier on in our presentation. So someone who has a prosthetic cardiac valve, has had previous infective carditis, has a congenital heart disease, or cardiac transplant recipients who develop a cardiac valvulopathy. So we're talking about a relatively small group of patients who should be receiving this prevention. In terms of when, it's really all dental procedures that involve manipulation of gingival tissue or periapical region of the teeth, or perforation of the oral mucosa. So, and there's a really nice table if you take a look at the guidelines in terms of really what that doesn't involve. So take a look at that for some additional details, and if folks want additional clarification, I'm happy to provide that during the question and answer session. And then in terms of the with what, there's lots of different options. Amoxicillin 2 gram once is a single dose, 30 to 60 minutes prior to the procedure, is probably going to be the most common thing that you'll see in a community pharmacy. There are some IV alternatives, and then some alternatives for patients who have a penicillin allergy. So that's a quick review of who should get prevention, when they should get prevention, and what you're going to use to prevent infective endocarditis. So this is a tough topic, I know. I wanted to just go over a quick summary and then I'll open it up for questions. Endocarditis, it's an important and serious infectious disease, even though it's not as common as some of the other items we're going to be talking about. The most likely pathogens really are determined by the clinical course of the patient. So remember, way back to the beginning of our talk, is it a very quick onset, or has it been more of an indolent onset? We also, again, want to keep in mind the risk factors and the type of valve, because that really is going to determine our pathogens and the regimen that we're going to select. So we talked about the treatment is determined by the organism and the type of valve, and prevention is recommended in a very limited group of patients. So I think it's an important thing to know and to be able to educate our patients about.